Thanks again. So this is about PAP therapy and how you take decisions. And I think one thing we have to understand is that in positive airway pressure, we are taking decisions all the time, but I think one thing we are not trained on is how to communicate these decisions. And I see a lot of postgraduate students and colleagues highly competent, and when patients come for a second opinion, I've always introspected on why would they come at all from a competent other respiratory physician. And I often find that the issue is two things. One is that they never got adequate time with that doctor, and the other is they just didn't understand what was going on. So when you make decisions, I think it's important that you all realize that you may make the best decision in the world for the patient, but if you haven't communicated it well, that's not going to get across. So I think that's one thing I really want to leave you all with. Hopefully I'll keep this as short as possible so that you all can go for a well-deserved tea coffee break. So there are 5 issues I want to cover here. Communicating decisions. You've taken a decision, how do you communicate it? A lot of this has got to do with underdiagnosis. So if you look at awareness among doctors themselves, and you see how low it was. This was some years ago, and this is obviously improving, and conferences like this are what open many people's, many medical professionals' eyes, especially respiratory physicians who are new to sleep apnea surgery in a large sense. I think these sort of things really open you up. The awareness lack was so bad, even among trained doctors, medical students surveyed, nursing staff, that there's so much good work that can be done in just improving awareness. There's ignorance, there's denial. As Dr. Jeevanand said, there's so much, whatever the gender of the patient, I think there's a lot of denial when it comes to snoring. This is an elaborate test. People think that they've got to go through. Whenever there are wires strapped to the body and the patient is not aware when the test is going on, like when they're asleep, I think they are a bit reluctant very often. Costs vary across the country. There's no standardization of cost here. Compliance issues and the size of the machine, just looking at that machine, can scare off a lot of people. And denial is very understandable. Denial is not just in sleep apnea, it's there in many diseases. It makes the patient feel more vulnerable. They try not to face reality and downplay the consequence of the issue. And as one of my neurology colleagues said, in a dying patient, which we often face in respiratory medicine, he says hope is the biggest challenge when it comes to reality. Hope and reality just don't seem to go together. You know, you'll have this patient without any realistic hope of surviving, but you still have the family with hope. So these things play in a patient's mind, and they just don't want to accept things at times. And you know, after all, they wake up, right? So it's easy to buy time. It's convenient to buy time because you don't perceive what's happening. And this is very common with both obesity, which I said in my last talk, OHS, and OSA. That's why patients are first diagnosed in the ICU with OHS. And someone mentioned that it's like a terminal cancer. It made me start thinking really of how we deal with many of these patients and their problems. So delayed diagnosis is very much there. And all this data is there to tell you that how long it takes for patients to get. And I think what we need to learn better when it comes to decision making is how to communicate the need for a sleep study. How to communicate to a patient on positive airway pressure, how to communicate on other treatments and NIV. We have to understand these things to communicate. You can't just say get this patient onto CPAP. And how to communicate during follow-up, because many people don't even know when and why to call for follow-up. Someone's doing well on CPAP, forget about the patient, but you have to, because now you have surgical options, you have so many other options besides positive airway pressure. One important thing, and these slides are often used to explain to patients how bad sleep apnea can be as a condition. is what does the obstruction do? And we often tell them the apnea causes hypoxia. And hypoxia is really dropping the oxygen supply. And these are slides you've got to use to tell them how serious the condition is. And this causes an arousal. The arousal stimulates the sympathetic nervous system, systemic vasoconstriction, increased workload on the heart, and increased oxygen demand. It's a double whammy on the heart. So cardiovascular health is really affected, regardless of the SAVE and the IASSAC studies, which were negative. This is enough to tell you that there is cardiovascular compromise, and that's why pulmonary artery pressures go up. And so you have reduced oxygen supply to the heart because of the obstruction, and you have an increased oxygen demand on the heart. So both ways, the cardiovascular system is compromised. So why would you do this study? You want to improve diabetes control, and many of you all may have seen patients whose blood sugar medications start coming down. It improves blood pressure control, reduces the number of meds, reduces the risk of stroke, memory loss, and cognitive decline data now emerging, and of course reduces all the hazards of excess daytime sleepiness, road traffic accidents, workout, which I think is like under the sea iceberg kind of effect, which we don't even realize. We hear about an accident, the driver has fallen asleep, multiple people have died, but it never gets the awareness and attention that it really needs. Another thing on PAP therapy, and again this is, I know decision making on PAP therapy is not something that surgeons often do, but may want to get involved in, is when you do a titration, what is split night, what is auto CPAP? The simplest test is an overnight oximetry. To me as a respiratory physician, I find it one of the most underutilized tests. You can decide whether a patient needs nocturnal oxygen with chronic lung disease based on this test. And then you have the apnea link study, of course, which is a simple screening study. The apnea link, as you can see here, is a very good screening study. It has 4 channels and 5 channels in the new version. And you get quite a lot of information on this study. The full PSG can be attended or unattended when it's done at home, and sometimes attended at home, and we check all the parameters that you heard in earlier talks. And if the sleep apnea is severe and you want to save time of the patient, especially when patients have come from another smaller town, they want to know the diagnosis, they want to know if they will tolerate CPAP in one night, you can do a split night study. And so the titration is, you want to know, does the PAP correct the sleep apnea? You want to know with different masks, at 2 o'clock in the morning he's not tolerating one of the masks, which mask will help him? Has sleep efficiency improved in the patient? And that's what you see very clearly in a split night study. You will see 84 or 80% sleep efficiency in the first 4 hours. You put the mask on, look at the sleep efficiency, it's gone up to above 90 most often. Has the quantum of REM sleep improved, which was say below 20%, has that gone up? And have oxygen saturation and AHI improved? So much information in one night with a split night. So you can only do this, of course, if your apnea-hypopnea index is say above 15 or 20 at least. So when you strongly suspect OSA, and when your AHI is more than 20 at around 2 o'clock, 3 o'clock in the morning, you can go to a split night. And when you want to save time. And when the cost for a dedicated sleep study alone is a little high, you may want to straight move to split night to solve everything in one night. Adherence, when it comes to adherence, there's good evidence to show that laboratory and hospital studies are pretty good and home studies are equally good. And there's good evidence to show that adherence is the same. However, education received should also be the same ideally. So in a hospital you have more time with the patient. In a home study, the technician comes in, hooks the patient on, is sometimes gone if it's an unattended study, comes back in the morning, takes the equipment, and that's it. And then when he starts using CPAP, there's no call for follow-up, which is what I'm going to come to. So you need to make those decisions on treatment. And what are the decisions we need to make? Should it be a nasal mask or an oronasal mask? Should it be bilevel? Bilevel is when the pressures are really high, morbidly obese patients, when the PCO2 is elevated, associated chronic airway disease, or the patient is just intolerant to CPAP, he may need bilevel. The other treatments we have gone through most of the morning, but remember that a lot of this is still under research. Atomoxetine and an anticholinergic oxybutyrin have been tried. Surgery we have heard a lot about. And hypoglossal nerve stimulation, the STAR trial, as we all know, showed an AHI reduction of 29 down to 9. And now there's a hypoglossal nerve stimulator, I don't know if any of you all have seen it, called the Excite portable device, which is just clipped onto the tongue for 15 minutes every day for 3 weeks. That has also shown AHI reduction. But these are not yet available in India, and they will get available, and there are different ways in which patients can probably look at alternatives, especially if they have mild, moderate sleep apnea. But you've also got to remember other important things. You can't just say PAP therapy. So when you take a decision on PAP therapy, the first thing the patient is going to ask you is there an alternative? Positional therapy is extremely important in mild, moderate sleep apnea, and you have devices now that are actually attached to the neck, which can actually stimulate the patient to move position when the patient is in a supine position and move to the left or right. And so positional therapy has become very interesting in that it has shown decreases in AHI. Sedatives, interestingly, you would think are to be avoided, but in some patients, when you want to take that decision on PAP therapy and the patient has insomnia, you may want to use a sedative for the first 2 weeks so that the patient sleeps better and tolerates the CPAP therapy better. So don't think sedatives are an absolute no. Sometimes you need to use them very judiciously, and S-zopiclone for maybe 2 weeks when you're starting CPAP helps the patient tolerate and then take it off. Obviously you don't want them to use it regularly. Rhinitis is controversial. There have been various studies on this, but I would say definitely not nasal decongestants for a long time. At the most, maybe when you want initial tolerance for a few days, you may want to use it. And nasal corticosteroids have been tried. And the consensus statement published this year by Chang is outstanding. For those of you who want to read all about the evidence in sleep apnea, the statement from Chang from UCSF has covered every trial in every treatment modality, including PAP. So remember that nasal dilators have also been tried, and you get these patients who tell you about nasal dilators. Interesting to note that in some patients who have nasal obstruction, you could use the nasal dilator along with PAP, improves the patency of the nose and improves CPAP adherence. So interesting stuff coming out. Oxygen perioperatively. So if you have a cranioskull-based surgery happening, then you may not, obviously you cannot use CPAP post-op, and you'd like to use oxygen there, and probably with a mask. Comorbid CCF, COPD, oxygen, but largely oxygen alone for CPAP treatment, not recommended. Myofunctional therapy, we heard Rahul talking about it and many other speakers. And primary surgery, there's an interesting trial on primary surgery versus UPP versus CPAP, which showed a 31% increased mortality with CPAP, which was really interesting. I haven't read that study in detail, but I was looking at straight going for surgery rather than CPAP, and a lot of data in this space, which I think we respiratory physicians need to learn more about, because that's where I guess treatment will start molding as people tend to get fed up using CPAP every night. Can you do unattended auto PAP titration? You may have heard of people telling you, let's just put him on auto CPAP and we'll know it. You can do it, but please don't do it in patients with chronic heart failure who have central sleep apnea. Very dangerous to do it in such patients. And for anyone who has hypoxemia for reasons other than sleep apnea, auto CPAP titration should not be done. Remember, these patients can have central apneas, and you don't want them on an auto CPAP. The auto CPAP machine will sense there is just no obstruction and won't deliver any pressure. So that's an important rule to remember. How do you set the pressures in CPAP? Check the AHI, the REM-AHI, see the difference. So when you're setting auto CPAP, look at the difference. It does a huge difference. You may want to give this patient auto CPAP and set the pressures plus or minus 2 centimeters from the 95th percentile pressure. So the titration will tell you what the 95th percentile pressure is and set it plus or minus 2. And you'll probably learn more during workshops.
So we are almost out of time.
Yeah, this is the last few slides. Traveling with CPAP, you have the Air Mini now. So patients who want a small machine to travel, you have very small machines available. And perioperative, as I said, avoid using CPAP in patients with facial trauma, burns, copious respiratory secretions in skull base, or vital wall surgery. And after nasal surgery, if you have to use a full face mask, and avoid CPAP after maxillofacial surgery. So other things to do is avoid opioid analgesics if possible. NSAIDs, paracetamol should be okay, and you heard in the last talk about dexmedetomidine. And finally, follow up. Of course, all these are the questions you need to ask patients about daytime symptoms, hours of use, and you get this all on the data card. And you'll have, there are 3 things you need to understand when it comes to the mask. Discomforts with positive airway. It's either the mask, the pressure, or the nose. One of these 3 things. And you need to sort out these 3 things when patients are intolerant, with probably what is there in brackets will help you sort these things out. Okay, and you have, I don't want to go, you have cloud connectivity. And finally, just one thing is that when you're a sleep specialist, a lot of patients land up coming to you with insomnia. And I think many of us don't realize that insomnia is actually a psychiatric condition and not, it doesn't come under the purview of respiratory or ENT medicine. And so understand your basics of insomnia is what a message I leave you with. The treatment of insomnia is sleep hygiene followed by cognitive behavioral therapy, and the last thing is a drug. So please remember this order of treatment of insomnia, which will go a long way. Okay, and to conclude, communicate well, decide which study to do, decide when to call and what to check at the follow-up, and decide when to involve, why, and when to involve a surgeon as early as possible. Thank you very much. Thank you.
Thank you, Dr. Sujeet.
Sorry for the